Hello, good afternoon, everyone. Thank you so much for joining us on this webinar on high-yield platelet and coagulation pathway disorders. My name is Moses Murdoch. I am an internal medicine resident, a self-described hematology geek going into hem-onc, and I've also been a tutor for the USMLE and complex exams with med school tutors and Blueprint Bio. And it is my pleasure to be joined by Dr. Nathan Loudon. Nate, why don't you introduce yourself?
Yeah, hey guys, I'm Nate Loudon. I'm a second year interventional radiology resident at the University of Michigan, and I've been tutoring with med school tutors slash Blueprint test prep for a little while, and excited to talk to you guys about platelets and coagulation cascade.
Awesome. So first, just a very brief word on who we are and why we're here. We know that you're here for the high yield facts, but just a quick blurb. We, as mentioned, are a one-on-one online tutoring and plus company that really focuses on the full pathway through medicine and through the examinations that are sort of the major hurdles through that process. We've been doing this for quite a while, and all of us are folks who have gone through the process. We've had to sit there long hours studying for these exams. We've progressed through them from medical school. We have attendings, fellows, residents like Nate and I. And I hope, as you'll see tonight, we really love to teach. We enjoy that sort of one-on-one personalized interaction. And throughout the webinar, you'll see the contact information at the bottom of our slides. If any of this sounds interesting to you, feel free to reach out. We would love to hear from you. Just to give you all a bit of a roadmap as to what we'll be covering today. No surprises here. As the name implies, we'll focus on platelets and the coagulation cascade. It can really often feel like a jumble of letters and numbers, things interacting on a microscopic scale. We'll try to demystify that for you. And we'll try to integrate infographics. We'll integrate clinical images that might show up on your examinations, vignettes, so that you can tie the basic science facts back to either patient cases that you might see in real life, and certainly high yield questions that are commonly tested on these exams. At the end, we will have a period of live Q&A, but we really want to encourage your participation. So throughout, we'll be asking you questions. Please participate in the chat. You can send those messages either just to the panelists or to the entire group. And similarly, if you have questions, please put them in the chat. You'll notice that if Nate is talking and I'm just basking in his knowledge, I'll try to be typing in the chat, answering questions as they come up. But if we don't get to your question, definitely save it for the end. Some general tips, and then I'll turn it over to Nate. And these are tips that apply even beyond platelets and coagulation. These are just general test-taking tips. You'll notice we use a lot of histology and peripheral smears in this presentation. They can be intimidating. It's okay if you click next on that button, the next question comes up, you see a slide or a radiology study, and you don't immediately know what it is. It's important to stay calm and realize that you're integrating multiple sources of information. So the demographics of the patient, how old they are, where they're from, travel history, etc., as well as data that comes from the vitals and the exam, all complement the multimedia that might accompany your question. And you can often get to the right answer through process of elimination or other test-taking tips, even if you don't immediately know what's going on in the slide. In general, you will be tested on classic presentations of classic pathology, right? That's what residency is for, to expose yourself to all the different ways in which pathology can present. But for the purposes of these exams, typically they will present a very classic illness script for a particular disease. And so you don't have to be worried about being tricked in that way. And I use that word illness script pretty intentionally because that is basically the classic presentation that test writers use to test you on the basic science and the pathophysiology of these diseases. So having these mental models in your head, almost like what the classic patient looks like if they walked into the ED or into your clinic, can be really helpful because it ties buzzwords together and helps you really move through the vignettes in a quick and efficient manner. So all of that being said, I'm going to turn it over to Nate to then talk a little bit in more detail about the heme system.
Awesome. Yeah, great introduction. That's great. Thank you. So with all of this, kind of, I like to approach everything with a mindset of how can we understand why the thing that's wrong is wrong. So, you know, it doesn't really benefit us as much to think about things in terms of, oh, if I just remember, you know, memorize this, that, or the other. But if you actually like force yourself to kind of understand things, the memorization comes along with it. So with that in mind, we'll kind of lay a little foundation of what is going on with the blood hematology in general. So the classical benign hematology teaching, we talk about when there's a problem with cells, are there too few cells, too many cells, or cells that don't work right? And our discussion today is going to kind of center on those three buckets. And we'll talk about examples of each. But while we're kind of thinking about where do these cells come from, our cell lineages classically are divided up into the myeloid stem cell line and the lymphoid stem cell line. And we're all pretty familiar with all of these things, so I'm not going to belabor it too much, but just to say that, you know, lymphoid is where we get our natural killer T and B cells and plasma cells. And the myeloid includes all of our neutrophils, macrophages, basophils, all that stuff, red blood cells, and megakaryocytes and platelets. So platelets are kind of goofy because we call them cells, but they're really just like chunks of the mothership here, which is the megakaryocyte. And I think it's important to think for a second about where the megakaryocyte lives. So these guys all hang out in the bone marrow. So if we are seeing megakaryocytes on a like a slide, we know that that slide, they are showing us cells that came from the bone marrow. So we don't have megakaryocytes floating around out in our bloodstream. We have the little appendages that have broken off and are floating around, which are the platelets. And so we're going to talk a lot about platelets today. And then finally, malignant hematology is broken up into leukemias and lymphomas, and that's a topic, whole nother can of worms for a different day.
Yeah, 100%. I'm going to start calling megakaryocytes the mothership. I love that image. And you were just talking about the peripheral blood smear. Here's an example of a totally normal peripheral smear. This is at pretty low power, so we're not zoomed in a whole lot. And anytime you're looking at a peripheral smear, you know, what we hammer over and over again is a system of organization, whether it's reading a chest x-ray, whether it's reading a blood film, whether it's an approach to a clinical problem, you want to stay organized. So when you're looking at a peripheral blood smear, you're looking at the red cells. Are they the right amount of red cells? Is their shape abnormal? Is their distribution or relation to one another abnormal? You then look at the white cells, too many, too few. or are they abnormal in some way in the distribution of the cells that you see on the smear? And then lastly, you look at the platelets. And to be very honest, the platelets are sometimes a sort of forgotten child of the peripheral blood smear. You say, oh yeah, they're there, and then you sort of move on. The focus today will really be to show some love to the platelets. This is a totally normal smear, and at this magnification, you can't really see them all too well. I'll just use my cursor to point out, you can see some of them here, and as Nate was saying, they're fragments of the megakaryocyte. And at this power, you don't see the morphology, you can't see granules, you can't see any of that more advanced stuff that you might be tested on, and which we'll cover in a moment. But from a very high level, you're just asking, are there enough platelets, and is the relationship to one another appropriate? And that really brings us to the next slide, which we'll go into that in a little bit more detail.
Yeah, so when we're looking at these, this kind of illustrates what I was talking about earlier. So can you guys see my mouse? I don't know if I'm like moving my mouse around on the screen. No, it's fine. Anyway, the top left here is a megakaryocyte, and you can see it's kind of surrounded by all of these like weird, like heavily nucleated, kind of dark cells. Kind of, you can imagine they might. Some of them look a little immature, and that's because we're hanging out in the bone marrow. So, so there's a megakaryocyte. Then on the right here, we have normal platelets. And as Moses was saying, they're, once we kind of zoom in a little bit more, we can see that they're really full of these little granules. And we'll talk a little bit more in depth about what's in those granules when we talk about platelet activation on the next slide. But then finally, once they are activated, you get what we see in this bottom slide here, which is a platelet clump. So yeah, and that's sort of the basis for our platelet plug that we form in our blood vessels.
And that really dovetails nicely into talking about what's the point of having these little cytoplasmic blebs floating around in your blood by the millions. And that's really to maintain hemostasis. So as you can imagine, we as humans and as really organisms more broadly are sustaining injuries to our blood vessels or endothelium constantly. And if we didn't have a mechanism to repair, to plug up those holes that are made through biomechanical processes or even sort of inflammatory processes, we would lose the blood that's so critical to carry immune effector cells and red cells that carry oxygen, right? And the way that the human body has evolved to handle the need to maintain hemostasis is a two-step process. And we're going to talk about both steps of that process through the course of this webinar. The first is the platelets. This is a really nice figure from an NEJM article that goes over the key factors that mediate what happens immediately after an injury takes place. So immediately after there is disruption to the integrity of the endothelium, you have some neuro sort of hormonal changes that cause vasoconstriction and whatnot. But really what happens is that you have collagen that is exposed intraluminally in the blood vessel. And what you have is von Willebrand factor, which we'll talk more about in terms of pathology of that molecule later. But we have von Willebrand's factor, which comes from the alpha granules of the platelets. It also comes from the Weibel-Palade bodies in the endothelium itself. So you have the collagen, you have the von Willebrand's factor that comes up and links it to the platelet. And that's how the platelet adheres to the damaged endothelium. And that happens through the GP1B molecule. Once that anchoring takes place, that's just a lone platelet to a collagen molecule via von Willebrand's factor. We need to recruit friends. And so what happens next is that the platelet elaborates these molecules like ADP and like calcium that then promote the expression of a different molecule called GP2B3A. And that molecule then cross-links with other platelets. And as this process is happening across the area that is injured, you have platelets that are adhering to the damaged endothelium via von Willebrand's factor. You have the platelets interacting with each other through the GP2B3A fibrinogen, and that's a really key molecule we'll talk more about further in the coagulation cascade. And that forms the initial platelet plug. It's a weak plug, but it happens fast, and it's the first line of defense against insults to hemostasis. Now, I know that I just gave a bunch of words. I will review the key molecules here that you're most likely to be tested on. So the first is von Willebrand's factor. Remember, that's what binds collagen. Then it's GP1B. That is on the platelet, and it binds the von Willebrand factor that's bound to the collagen. And the third is GP2B3A. And that's how the platelets, through fibrinogen, are cross-linked to each other. As a preview, the whole point of the coagulation cascade is to take that weak sort of mesh of platelets sort of kind of sticking to each other and really tightening that up through modulation of the fibrinogen chemical reaction. So that's pretty high level. I probably glossed over some things. Nate, is there anything you would add to that description?
So I think you beautifully described it. I just wanted to say two quick things, and it has to do with sort of the clinical applications of this stuff. So another thing, in addition to ADP that the platelets release when they degranulate, is thromboxane A2 or TXA2. And it's important to know where this thing comes from and what it's derived from, which is, well, does anybody in the chat want to tell me where it's from? It's like bonus points, cool guy points. You guys are all cool. It's, you know, but it comes from cyclooxygenase. So, and can we think of any drugs that inhibit cyclooxygenase?
Don't be shy.
Irreversibly. Oh, yes, beautiful. Aspirin, NSAIDs. Awesome. Nice job, everybody. So this is like the exact mechanism through which aspirin exerts its antiplatelet effects. So by inhibiting cyclooxygenase, it's able to inhibit thromboxane A2, which interferes with this degranulation step in the platelet plug formation. So that's one way that we can pharmacologically interact with this whole system. The other way that's very commonly used in real life and tested is, let's say a patient comes in with slurred speech, right-sided weakness, and it all started, 2 hours ago, and you get a CT scan, it doesn't show a bleed. You really are clinically thinking, oh my gosh, this person is having a stroke. And you're not at a place that does, some sort of catheter-directed modalities. What do? You give a certain drug. What drug do we give these folks? TPA, every day. Yes, absolutely. So you give this person TPA, and does anybody know what that stands for? Sorry, why did I ask you that? Because it's going to take forever to type it out. Yes, awesome. So tissue plasminogen activator, and beautifully spelled, Eline, really nicely done. So so you give tissue plasminogen activator, and that converts plasminogen to plasmin, which breaks down this. And so we call that a fibrinolytic. Oh, fibrinolytic. So this is directly attacking this fibrinogen and fibrin, really, cross-linked fibrin, and breaking up that platelet plug. So that's how that works. So I like to contextualize these things that we talk about all the time.
Ever the consummate clinician.
That's right. So I'll let you talk about this one.
That sounds good. So here we're going to jump into cases, because I think learning from cases, from how the pathology and the histology and the pharmacology all come together is a great way to cement these concepts in your head. And we're going to start really from that organizational framework. Here we see a zoomed in view of a smear. And the first question we ask is too much, too little, or some other abnormality. And here I'm not going to torture you all because you're not expected to be able to quantify thrombocytosis or thrombocytopenia on a peripheral smear for the purposes of examinations. But I'll just say that the gestalt, which is just the fancy medicine word we use to sort of say hunch, is that there's too much. Thank you so much, Oscar. There's too much of this going on. And so that brings us to the concept of thrombocytosis. Some basic definitions: normal platelet count, 150 to 400. And if you have more than 400,000 per microliter, you're in the land of thrombocytosis. And whenever you see too much of something, you always ask yourself, is it too much because the body is appropriately responding to some physiologic change or insult? Or is the body sort of reacting, or not even reacting, but it's just sort of generating the cell line independently of any external stimulus in a sort of clonal way, right? And you'll see that on the slide. I have polyclonal and monoclonal causes of thrombocytosis. And this is fairly common. I have a patient right now that I'm taking care of with a platelet count of over 1 million because they have an infection and they don't have a spleen. So, and we'll get into why that's relevant later. But here is an opportunity. There's no wrong answer. In the chat, give me a polyclonal reason, in other words, a reactive reason why the platelet count might be high. And I sort of already gave one, and feel free to steal that one if you'd like. But if you can think of other reactive processes that lead to thrombocytosis, go ahead and put those in the chat. Perfect. So I'm seeing infection, so sepsis, asplenia, perfect. So, and that asplenia can be traumatic. Someone comes in after a car accident, they remove their spleen, and if you check it shortly thereafter, their platelets might be up. It might be due to something like sickle cell disease, right? Because of autoinfarction of the spleen. So that's all perfect. I'm seeing some wonderful examples of a monoclonal process in the chat as well, and we'll get to that in a moment. But just to really show how much you all already know, you've hit many of these: splenectomy, sepsis, some non-hematologic malignancies that then have a reactive thrombocytosis, autoimmune disease, right? Any cause of inflammation can cause a bit of a bump in the platelet count. The one that I wanted to highlight here, which is clinically relevant, it's probably not tested quite as often as others, especially at the step 1 or complex 1 level, is iron deficiency anemia. That's what IDA stands for. So sometimes you can see a bit of a reactive thrombocytosis when folks don't have their iron stores replete. Perfect. So now in the chat, what is the classic monoclonal cause of thrombocytosis? In other words, the bone marrow is producing platelets out the wazoo, and it's not reacting to anything. It's doing it in an autonomous manner. Some of you all already put that in the chat. Perfect. So what it boils down to is myeloproliferative neoplasms, which come, broadly speaking, in 3 flavors, although really only 2 of them are associated with super high platelet counts: polycythemia vera and ET, right, which is essential thrombocytosis. You can see it with CML, which is also a myeloproliferative neoplasm. And there is a gene and a mutation that they love to test. I mean, they love to test this thing. It's like on every single exam. What genetic abnormality is associated with the myeloproliferative neoplasms? And extra points if you get the actual mutation. Not usually necessary to know it, but it's nice as a bonus. And I'm seeing lots of right answers already. So that's the JAK2 V617F mutation. Because I'm a hemonc nerd and I just can't help myself, there are mutations in calreticulin and in MPL that can also lead to myeloproliferative neoplasms. I'll just point out, this is super cool. What is MPL? It's the thrombopoietin receptor. So it makes total sense. If you mutate the receptor that is telling the bone marrow when to create platelets, you throw a wrench in the circuitry and you end up with too many platelets.
Oh, that's fascinating. I didn't know that. That's super cool.
You're gonna have to stop me, Nate, or I'll just keep going and just
this is beautiful. I'm learning some stuff. This is awesome. Dropping knowledge here. The other thing I wanted to ask is why do we get thrombocytosis when we do a splenectomy?
What do y'all think in the chat? If you have a quick answer for this, throw it in. And if not, I'll let Nate drop that knowledge bomb.
This is the second time I've made this mistake of like, you know, requesting something that's a sentence, but yeah. So basically, essentially the reason is the spleen, yeah, loss of sequestration, boom, Deepak is bringing it. So it's your spleen actually holds about 1/3 of your platelets at any given time. And so you take that thing out and those little platelet fragments are just free to run wild. So that's why you get thrombocytosis. And, you know, this kind of equilibrates over time, but it's certainly in the immediate postoperative setting, you got to worry about it. All right.
Awesome.
So,
what do you think, Nate?
Yeah, what do you guys think? So Moses is pimping me on things that I, you know, don't often think about in my land of radiology, but I think I don't see a lot of platelets here, and so I think we're dealing with some thrombocytopenia. Hopefully, you guys agree with me. So, so with thrombocytopenia, there can be a few different causes, and so in terms of our diagnostic workup, this really nice diagram here kind of takes us down a few different pathways. So this first little branch point here is pseudo thrombocytopenia. That's I don't think they really test that on step 1, but like in real life, you'll have to think about that. But basically it boils down to are they being destroyed? Are they being sequestered? And if they're not being produced enough. And so if they are being destroyed, we have to ask ourselves, is it coming from immune-mediated causes, or is this some other sort of hemolytic or like, you know, overuse, we'll say. Yeah, so that's kind of where we look at it. And so the first thing we're going to look at is immune-mediated platelet destruction. And so the first thing we got to talk about when we're talking about immune-mediated platelet destruction is ITP. Now, when I first learned about ITP, I was like, oh my gosh, this is like so crazy. These, you know, this rare thing that like could never happen. I'll never see it. And then my first, you know, month on you know, internal medicine, I was, you know, I took care of a patient with ITP, and I was like, it's such a privilege to be training at this community hospital where I'm seeing ITP, and it's just everywhere. Okay, people get ITP. It's like super common. But so all that to say, all of us will see it in our careers, and it's really important to understand how it works. So the clinical presentation, if you know, if they're not asymptomatic, will be mucocutaneous bleeding. And this brings us to a really, really important point about the way that people with kind of quantitative platelet deficiencies will present. So if you have a problem with your primary hemostasis, the overarching like symptomatic presentation is going to be like little mucous membrane bleeding. So you'll get like nosebleeds, you'll get bleeding gums, and you'll get like petechiae, things like that. Whereas if we're talking about secondary hemostasis problems, we're going to have ecchymosis, like easy bruising. We're going to have problems with bleeding into your joints and things like that. And so, and the reason I harp on this is because this is how question writers are going to really try to clue you in to what might be going on with the person if they don't just outright give you the labs. And often, you know, they're going to do that. But it's important not only to understand the way question writers are going to ask us these things, but because we study for our patients, right? Because this is how these people present. So, all right. So all of that preachy stuff being said, what do you guys think? What are our antibodies being produced against in ITP here? Nice. GP2B3A. Beautiful. Nicely done. So exactly right. So, and if we think back for a second to our diagram that we talked about earlier, GP2B3A is the thing that links the platelets together, with fibrinogen being the rope between them that they're both holding onto. So now that we've talked about that, we have to think about how do we treat this? And this treatment is like so high yield, I've seen it in a bazillion questions over the course of my med school education. So do you guys know what the treatment is? Okay, yep. So rituximab is an option, but the first move is going to be glucocorticoids. And then the thing that for some reason they love to ask about is IVIG. So yeah, they like you to know that it's like the first thing you do is glucocorticoids. Then that doesn't work. Okay, we move to IVIG. And if that doesn't work, then we move to splenectomy. And I like the way that Dr. Sitar in Pathoma describes IVIG. So he describes the entire pathophysiology of ITP as being related to the spleen. And so when basically the splenic macrophages will eat all of our platelets up that have these antibodies against GP2B3A all over them. And by flooding the system with IVIG, we kind of distract those splenic macrophages, which allows the person's platelets to kind of rebound a little bit for a little while. But then, the distraction wears off and the splenic macrophages attack and attack and attack again. And so I think Moses can probably speak a little bit more in depth to the real life clinical management of these folks. But on a board prep level, you just need to know steroids, IVIG, splenectomy for refractory cases. And okay, so now we got to think about HIT. So the way that these guys will present is it's somebody who you give heparin to, and immediately, or let's say they were recently started on heparin or something like that, or they're in the hospital and you're trying to give them DVT prophylaxis and they're like clotting everywhere. And you're like, what the heck? Why is this person? I thought I was anticoagulating them, and now they're like making blood clots. And then you consult hematology, and they tell you to get antibodies against what? What antibody do we need to worry about? Well, I guess this isn't what you're. Yeah, absolutely. So I don't know if you actually order antibodies like a test against this heparin platelet factor 4 antibody. Yeah, you do. Sorry. Yes, you do. But so the thing to know is that yes, you have an antibody. This person has an antibody against heparin platelet factor 4. And there's one other test that you get to try and make this diagnosis. Does anybody know what test that is? No, it's not cold agglutinin, but I like that. I like where you're going with that. It is, yeah, serotonin release assay, SRA. So, and most importantly, the treatment, once you've made this diagnosis, what's the, if you're suspecting this, what should you do? Let's say they're in the ICU on a heparin drip. Yeah, stop that heparin. Walk on over and disconnect them from the heparin drip. And the nurse will be mad at you because you're not supposed to touch the IV. But you need to take them off heparin. And then but you also this person is now having like a clotting problem, and so you need to address that. And so you need to put them on some sort of alternative form of anticoagulation. And can anybody name just like some sort of type of anticoagulation besides heparin that we could put this person on? So the one that I have seen is argatroban. Nice, yeah, apixaban, sure, totally. So yeah, all right, so that's that.
Nate, that was awesome. The only thing I'll jump in and say is that what causes ITP? In a good chunk of patients, we never find out. It's idiopathic, right? And try as we like looking at history, looking at other labs, family history, we can't figure out why they have ITP. And so we just treat them for an immune sort of activation against this epitope that we don't otherwise know how to explain. There are associations with autoimmune diseases. And that makes sense, right? Autoimmunity means you're fighting against yourself. And in this case, the self is the platelet, the antigen that's present on the platelet. Maybe I'll just jump in and talk a little bit about the 4T score. This is, and we'll be brief because I know we have a lot of ground to cover. This is only to say that there have been studies that show that if you expose normal people to heparin, there's a good chunk of them that will develop antibodies against the PF4 heparin complex. But who never display clinical manifestations of HIT. And so because of that, you need a way to restratify folks, because otherwise you're not given heparin when you need to, and you're potentially exposing patients to other medications that they don't actually need. And so this is a score that you can use, and it really is beyond the scope of most tests, but just know that it has to do with the degree of how far the platelet count falls, the temporal association between the exposure to heparin and the clinical manifestations, the development of thrombosis, that's like the thing we really worry about, and then looking for other reasons why someone might have thrombocytopenia. Because as you might imagine, folks who are on heparin are on it for a reason. They have other comorbidities, they might be in the ICU, they might have infections, and you all don't have to memorize this score. You don't have to really think about this score on the exam, but we're here for value added, not just what's on step one, but what, or complex or any of these other exams, but for real life. I'll just comment briefly on non-immune platelet destruction, which I think of as mechanical, right? This is the rough and dirty sort of like we're going in and we're busting up some platelets. And you might be wondering, wait a second, this is a platelet talk, but you're showing me a picture of red cells. And that's because there is a really important morphology of the red cell that you need to identify that commonly coexists with non-immune mechanisms of platelet destruction. And that, as the folks in the chat have pointed out, is the schistocyte. So this is a schistocyte smack dab in the middle of this film. And when you see schistocytes with low platelets, you worry about a microangiopathic hemolytic anemia, right? And that hemolytic anemia comes along with often some thrombocytopenia. And so in the chat, can you all put any cause of microangiopathic hemolytic anemia you can think of? Any at all? And as you put it in the chat, maybe I'll just start shouting out some pearls. So don't be shy. Hemolytic uremic syndrome associated with E. coli, right? There's also atypical hemolytic uremic syndrome. DIC, the way you tell this apart from TTP, which I also see in the chat, is DIC has coagulation, like PT-INR abnormalities as opposed to TTP. TTP, Adams TS13, right? And it all circles back because it has to do with cleaving of von Willebrand multimers. Perfect. So here's a list of some other causes. So the hemolysis, elevated liver enzymes, and low platelet syndrome. There's sclerodermal renal crisis, autoimmunity comes back. And what I've also filled out in this chart is the macroangiopathic hemolytic anemia, which is basically where you have red cells passing through valves, for instance, prosthetic valves, and you shear them. That one likely doesn't have the same degree of thrombocytopenia, but for completeness, I've included it here. And then B12 deficiency, this is a weird one, can sometimes mimic a microangiopathic hemolytic anemia. That's like a super advanced concept, not something you have to worry about. The thing you all have to really remember is that if you see anemia, thrombocytopenia, and schistocytes, you have to think about a microangiopathic process, and then you're looking for other clues. Do they have kidney dysfunction predominant? Do they have neurologic involvement, which would support more TTP? Do they have an infectious exposure, making you think of HUS? And that's how you start really drilling down, eliminating things, and getting to the right answer. Anything to add here, Nate?
Yeah, no, I think that's awesome. I think being able to recognize TTP and HUS is super high yield. Like it's that fever, anemia, thrombocytopenia, renal and neurologic problems. And the emphasis, like you said, is either going to be on renal and HUS or neuro and TTP. And then DIC is like so freaking important, I think, in real life and on the test, because you'll see it over and over in your Q banks and on the actual test. And one of the important buzzwords that should make you like alarm bells go off is bleeding from IV sites. If they talk about that, they in real life, it could be other things. They're probably trying to clue you into DIC. And it's important to think about like what the cause of DIC is. And I think it's something that's been drilled into probably all of us by now. And it's that combination of overactivation of platelets superimposed on like consumption. So you have like clotting and bleeding going on at the same time, which is obviously a horrible problem to have to face. So that's all I wanted to add.
No, and that's super high yield. What I'll also point out is just like in ITP, the next question is, why do they have ITP? When you see DIC, the next question is, why do they have DIC? And that is critical, because the treatment for DIC is not correcting labs. That is a fool's sort of task. The way to treat TTP is to figure out why they have TTP and deal with that. So super common things that cause DIC would be sepsis. They're in the ICU, they have a terrible bacteremia, they're hypotensive, they're on pressors. Oh shoot, now they're bleeding from all their IV lines. The one that you all should know for the exam, because it's incredibly rare, but folks love this, is acute promyelocytic leukemia. So you can end up with DIC through some forms of leukemia. Also malignancies in general, they express tissue factor on their surface. They kick off this crazy coagulation cascade process. The platelets get involved. And so you're always asking, how do you, like, why do they have DIC? How do I deal with that underlying process? And the question about how to figure out what is DIC and what is HIT, a lot of that is clinical, right? So HIT will have low platelets, but they won't generally have the coagulation abnormalities that DIC has. And then DIC will have the syndrome, the clinical syndrome that then leads to the DIC, which you don't see in HIT. And then in terms of which drugs cause destruction, oh my gosh, which drugs don't cause thrombocytopenia? I will point out that one of the really common ones is actually antibiotics. So like penicillins and stuff like that. But I would, before your exam, if you're like worried about that question, I would quickly go to first aid and just like look at that list, because it's really extensive and it would take too long to go through all of them.
Doesn't linezolid also like classically do it?
Yeah, linezolid classically does it. Linezolid is a bad drug long term, because it also just causes cytopenias more generally, which is no bueno. But yeah, a bunch of antibiotics. That's a very common culprit.
Yeah. Cool.
All right, platelets not working right. Take it away.
All right. So when we think about this, we can kind of divide it up, or at least I like to divide it up into is there something structurally wrong with the platelet, i.e. We've got like some sort of genetic deficiency in our platelets, or there's something else going on where you also have some immunologic problems that go along with it. And there's a couple of important syndromes that have both immunologic issues and platelet issues, and and it's important for us to like understand why they are that way. So we'll talk about them momentarily. So first off, structurally, can anybody think of problems? Let's see. Can somebody tell me? Oh, geez, I'm doing this again. So basically, anybody think of some sort of problem with your platelets that's like genetic? Okay, von Willebrand's factor. So yeah, Glanzman is one of them. And we'll get to von Willebrand's factor a little later on in this discussion, but yes, WisconAldrich is going to be in our immunodeficiency pile. So yeah, Glanzman thrombocytopenia, Bernard-Soulier, and then we'll get to the immunodeficiency after. But sneak preview, one of them has been named already. All right, so Bernard-Soulier. I will tell you guys that one of these is a problem with GP1B, and one of them is a problem with GP2B3A. So can anybody tell me which one is, yeah, bingo. So nice job, Nadia. Yes, GP1B is the Bernard-Soulier defect. And recall, that is the one that allows for adhesion. And then just to remind ourselves, GP2B3A is the one that connects to the fibrinogen rope and is responsible for joining other platelets together. So Glanzman thrombocytopenia is a genetic deficiency in GP2B3A, therefore impairing aggregation. All right, so somebody mentioned WisconAldrich, and hopefully I'm WisconAldrich, I don't know. So that's one of these immunodeficiency ones. And I'm just going to say the other one because I don't want to make you guys like try and spell this. The other one is Chediak-Higashi syndrome. And so we'll talk for a second about like the unique features of each of these and why they occur. So WisconAldrich or Aldrich is a deficiency in a certain gene. Can anybody tell me what gene it is? And absolutely, Eleni is telling us that actin is messed up in it. And yes, so we've got a WASP gene mutation that causes actin malfunction. And so I think it's important to remind ourselves the job of actin is it's the cytoskeletal element. And so if you have a problem with your actin, your platelets cannot degranulate appropriately. And thus you get this like thrombocytopenia. Additionally, your leukocytes also rely on actin. And so you're going to end up with recurrent infections. And the other interesting feature of this that they will often talk about on exams is eczema. These patients have eczema. And what goes along with eczema is increased IgE. So they're going to have increased IgE and increased IgA. And then finally, they'll have like tiny little platelets. Oh yeah, I forgot to mention, which one of these things has big platelets? Somebody's going to tell me. Bernard-Soulier. Sorry, I kind of misled you, Eleni, by talking about that in the immunodeficiency spot. But yes, it's Bernard-Soulier. And as Sitar says, it's big suckers. I don't know. You can tell I've watched Pathoma way too many times. Just kidding. You could never watch it too many times. It's the best. All right. So Chediak-Higashi syndrome. So this also is a cytoskeletal element problem, but it comes from a gene issue. And can anybody tell me the gene that's messed up? List. Beautiful. So yeah, you have a list gene defect, and that causes microtubule dysfunction. And the reason that this becomes important is, microtubules, you'll recall, are this like important cytoskeletal element that's used for like lysosomal and phagosomal like trafficking throughout the cell. And so basically, I think of it as like you have all of these clumps of not so well working lysosomes piling up in the cell, and you have these big granules is what that results in. And that's what this bottom picture here is showing us, is these big granules inside this neutrophil. And the other thing that is unique about this is, can anybody tell me what these people's skin looks like if you were to see this person in real life? Pale, yes, they have albinism. And when we think about what makes our skin dark, yes, it's low melanin transport. And so melanin is found in these melanosomes, and if those things cannot be transported to the cell surface, like as in along these microtubule scaffolds, these people will be albino, and hey, that's what they are. So this all goes back to explain to us that this is a microtubule problem. The other problems related to microtubules that these folks have is neurodegeneration. They get peripheral neuropathy, and they have recurrent infections. But honestly, if you are going to get asked about this, they are probably going to show you this picture right here that we're showing you. If I've ever seen it on a test question, they've like showed me this and been like, what is it? So now you know, and now you know why. That's the important thing, is putting the why together with all this.
100%. I love these immunodeficiencies. For Shinya Kagashi, the way I remember and tie together all the clinical manifestations is realizing that microtubules are important, like for instance, in nerves. They're super long cells, right? So they need to transport stuff back and forth, just like the melanocytes do. And hopefully what we're doing here is bridging different disciplines, right? We have immunodeficiencies, you have the whole infection conversation, but then you have sort of non-immune cell implications, such as when their platelets don't work, right? Because remember, again, spaced repetition here, the platelets themselves have granules, and those granules need to move around, and they need to degranulate, right? You have the alpha granules with the von Willebrand's factor, with the fibrinogen, the fibronectin. You have the dense granules with the calcium and the ADP. The fundamental cellular biology is often very similar across these different cells, and they manifest in pathology depending on the cell and tissue type. So super cool. I'm a huge nerd, as you all are quickly finding out. I want to make sure that we have time for some questions and answers at the end. So I apologize if we don't get through all of the coagulation cascade, but I think that what we can do is maybe talk about it in pretty broad strokes, and maybe the first clinical case, and then we'll open things up to questions, and we'll try to sneak in, if we can, another webinar with the full coagulation cascade, because there's a lot to digest here. What I'll generally say is to, again, ground ourselves. It's easy to get lost in the details here, remembering each of the factors in the intrinsic and the extrinsic pathway. It's important to remind ourselves how we got here, and it really ties together with what we were just talking about. So you have an insult to your endothelium. You need a way to stop bleeding, to maintain hemostasis. The first line of defense, as Nate was beautifully talking about, was the platelets, right? As they adhere to the collagen via von Willebrand's factor and GP1B, and to each other through GB2B3A and fibrinogen. But that is an imperfect solution to the problem because it's weak. And the whole point of the coagulation cascade, as you can see with this sort of reddish orangish fibrin, is strengthening that mesh so that you have a strong barrier preventing bleeding. And the whole point of the coagulation cascade is I don't care how this injury happens, we're going to end up here. We need a way to catch all of the injury and funnel it down so that we strengthen that platelet plug. And the whole point of each of these arms is detecting that damage. So you either have extrinsic pathway where tissue factor, right, initiates the process of generating a strong platelet plug through fibrin interconnections, or you have the intrinsic pathway, right, where the same sorts of insults that led to the platelet plug in the first place also lead to the generation of the fibrin. The key thing to remember is that the final common pathway involves factor 10 and factor 2. Why am I highlighting those in particular? And the reason is that all of the anticoagulants or many of the anticoagulants that we use target either factor 10 or factor 2, right? And the reason they're so effective is because they are the central pathway through which all of this works. So if you want to stop if you want to really anticoagulate effectively, you target that common pathway. And there are diseases that target each of these different or many of these individual factors. So for instance, factor 5 Leiden, which we may get to, such as the deficiencies in some of the intrinsic pathway factors. If you can keep this straight and keep the big picture in mind, I think that would really go a long way. So let's see how many vignettes we can get through, and then we'll open it up to questions. Nate, tell us about some of these bleeding phenotypes.
Absolutely. So kind of going back to what we were talking about earlier, if you have a coagulation cascade disorder, you're going to get this right here, bleeding into your joints. And so that's hemarthroses. You've got bruising as well. And then another very important thing that they will talk about is post-operative bleeding or bleeding after a dental procedure. And so this comes back to usually if we're talking about a hemophilia, we're talking about hemophilias A, B, and C. And who can tell me which factor is messed up in hemophilia A? Yeah, 8, awesome. And is that X-linked or autosomal recessive? Awesome, X-linked. And what's wrong in hemophilia B? 9, awesome. And is that autosomal or X-linked? X-linked, awesome. And hemophilia C, what's wrong there? Boom, 11. So we're just kind of sequentially walking our way out the coagulation cascade in a way. Skipping 10. And this is autosomal recessive. And so basically you just need to remember that the C is the exception to the rule, and these other two are X-linked recessive. Now, briefly, let's talk about how on earth does desmopressin play into all of this. So first off, what is desmopressin? It is a synthetic analog of vasopressin that well, basically, so vasopressin acts on 2 different receptors, and one of them is V1 and one of them is V2. Can anybody tell me where V2 lives? No. So this is yeah, nice, awesome. Doshia coming in hot. So it's in the distal tubule of the kidney. That's where V2 lives. And so vasopressin is also known as ADH, and that will bind to V2, but vasopressin also binds to V1, which causes a transient vasoconstriction. But desmopressin has a preferential binding to the V2 receptor. And this V2 receptor is also involved in the release of von Willebrand's factor, which Crystal nicely pointed out to us. And so so in addition to releasing von Willebrand's factor, it also releases factor 8. And so that's how this all ties in. So we give desmopressin for its increased release of factor 8 and von Willebrand's factor. And then obviously, if you've got a deficiency in a factor, just replace the factor. And that's what this factor concentrates thing is getting at.
Love it. I think this next point maybe will be our last before we open it up for a couple of minutes of questions. And it gets at a question that's pretty common, which is you can either have a problem with a factor because the factor is just missing. In other words, it's not being synthesized, or it's not being put in the blood. And that's inherited, as we've just described, X-linked recessive in A and B and autosomal recessive in C. Or you can have an acquired form where you have an inhibitor that is sort of destroying or preventing the function of the factor. And so how do you tell the difference between an inherited and an acquired coagulopathy? And specifically, I'm talking about hemophilia and an inhibitor. There is a test that you can use to make that distinction. What test might that be? Go ahead and put in the chat. What might we do to tell the difference? I love it. Yeah. So it's a mixing study. And what a mixing study does is that if you mix in serum that has all of the factors appropriately in their appropriate concentrations, if it's just missing, you will give enough such that it will correct your coag panel, right? Whereas if you have an inhibitor and that inhibitor is present at a sufficient concentration, then you can add in more factor, but that inhibitor is just going to be like, so what? I'm still here. I'm still going to inhibit you, and it's not going to correct. And so that's one way that you can start to make a distinction between just the congenital absence of a factor and otherwise an inhibitor that is more of an acquired process. All right, so here is where we're going to pause and want to be respectful of all of your time. I will open it up to questions at this point. And if you all are wanting clarification on anything that we've talked about, this would be a great time to go ahead and put that in the chat. We are here for a couple of minutes, would love to chat with you. And I'm just pulling up again that the information on who we are and how to get a hold of us before we jump into a couple of questions. Ooh, this is an advanced question. General rules on when to use IVIG and Plex. So I will give you sort of the test answer, which is going to be a little bit of a sidestep. The real answer is that I'm not sure that there are clinical trials that have done head-to-head comparisons. If there are, I'm not aware of them. The most important point is you will not be necessarily asked to make this distinction on the exam, at least at the step 1 level. The key thing is you can't do both, right? Because if you're giving IVIG and then you're using Plex to remove it, you've undone your own work. So you typically want to do one or the other. And you won't be asked necessarily for indications of one to another, unless you, Nate, you can think of a specific indication.
No, I don't think so.
Yeah.
Yeah.
And this is a good point actually that's being put in the chat, which is that IVIG is used more for ITP and Plex is used more for TTP. So I think that is actually true.
Yeah, Plex being plasma exchange. Took me a second to figure that out. Sorry.
Yeah, sorry, plasma exchange. Any other questions? Don't be shy, folks.
Yeah, you have a world-renowned expert in hematology right here before you.
Hopeful.
The illustrious Dr. Moses Murdoch.
as you all are thinking, I'll just sort of give my concluding remarks, which is that it's easy to get lost in the weeds. Try to remember the fundamental principles. Try to find joy in what you're studying. Try to be communal in your studying. We're all going through this together. Our goals are all the same at the end of the day, to take really great care of patients. So whether that's a close buddy from school or someone across the country or a tutor, whoever it is, try to stay social, stay connected, stay well during these times. And yes, hypoxia is a polyclonal cause of thrombocytosis. Sometimes even smoking can be a cause of more likely high red blood cells and platelets, to be honest, like OSA, smoking, altitude, etc. But that is definitely true. Nate, do you want to attack Jackie's question, or do you want me to?
Let's see. How can we tell the patient has chemotherapy? So it has to do with like, essentially what you'll do is you'll have these like different wells with either the antibody or the patient's serum, and you can add the missing factor to the patient's serum to see if it corrects the problem. If it does not, then you can kind of infer from that the patient's serum includes antibodies that are destroying the thing that you just added to it. Does that make sense? So the serum is like the parts of the blood that are not like the red blood cells, and so it's, and maybe I'm getting my definitions goofy, but the point is you put the you put the missing piece in there and you see if it fixes it. If it fixes it, great. Then you know that it's not from an autoantibody. Awesome, sweet.
And the one point I would make, just to clarify, is that the mixing study will help you tell the difference between an inhibitor and a congenital, like a hemophilia. It won't tell you the difference between two different hemophilias. It won't tell you the difference between hemophilia A and B. They're both part of the sort of intrinsic pathway, right? And so it's more trying to figure out, is there an inhibitor or is there just the absence of a factor? And the other, an inhibitor is an antibody, like it's an antibody that's being produced in an autoimmune sort of type fashion against a factor. So you can think of it as sort of like the ITP of factors. So sorry if that wasn't clear. Inhibitor means an antibody that's destroying a factor. All right. Last call for questions.
I'll just chime in my own concluding remarks while whoever's saying whatever they want to say can say something. But thank you guys so much for coming. And I also want to echo what Moses was saying. Find somebody to go through this with. It's great if you can. And it can be really, really painful, and it's a slog preparing for these board exams. And so, take the appropriate amount of time that you need to do whatever amount of wellness is required to get through this time. And just when it gets tough, I find that it's like really important to remember why you're doing this, and remember the things that like made you want to be a doctor in the first place. And if you can kind of tap into that, it really makes a big difference and can help you reframe studying. And as I said earlier, it's all about studying for your patients, not for the exam. So you are studying for an exam, but really it's so that you can have an understanding of medicine that helps you make a difference in somebody's life someday, which is like so freaking cool that we get to do this. So anyway, thank you guys so much for your attention and for participating. You guys have been like super, super fun to talk to.
Couldn't have said it better.